Oh, hello, what's up? Hi, guys. Wait a second. Oh, hello, what's up? Hi, guys. Oh, hello, what's up? So, we are live. We are live now. We are back again, and this will be the second part of the adrenergic drugs. And in this part, we will be discussing the drugs, right? In the last part, we have done the actions, receptors, then vasomotor reversal of Dale and re-reversal of Dale, right? Then adverse effects. Now our main motive is to complete the drugs, right? Hi Prakhar, what's up? So guys, welcome to Unacademy, the top online learning platform. So here we are having two subscription options, Plus and Iconic. So if you want to buy Plus, then there are many advantages, like you can attend live classes, you can take live test quizzes, and you can enroll into the batch courses, and you will be getting the structured schedule. Plus you are having a second option, the Iconic course, and if you are a second or third year medical student, then I would suggest you this. So in this, you get benefit of Unacademy, right? You get benefit of live classes, live tests, quizzes, batch courses, and structured schedule. Plus you get benefit of the prep ladder as well. So Iconic course is the collaboration between the Unacademy and the prep ladder. So in the Iconic course, you will be allowed to view the pre-recorded video lectures. You can take QBank questions from QBank 2.0 rapid revision course, and you will be getting the handwritten notes. And yeah, so if you want to buy the Plus or Iconic course, then you can use the code VIRMANI Virmani, and you will be getting 10% off, right? And now let's get started with our topic, that is adrenergic drugs. So guys, in the last session we have talked about the catecholamines, and catecholamines are the only endogenous neurotransmitters that stimulates the adrenergic system or the sympathetic system, right? And catecholamines consist of the three substances: noradrenaline, adrenaline, and dopamine. So noradrenaline, it acts as transmitter at postganglionic synaptic sites except sweat gland, hair follicles, and some vasodilator fibers, and in certain areas of brain as well. Then adrenaline is secreted by the adrenal medulla and have a transmitter role in the brain. Then dopamine is the major transmitter in the basal ganglia, limbic system, CTZ, anterior pituitary, and in the limited manner in the periphery. Then synthesis of catecholamines. Catecholamines are synthesized by the amino acid phenylalanine. Right, so phenylalanine is converted to the tyrosine, tyrosine is converted to the dopa, dopa is converted to the dopamine, dopamine is converted to the noradrenaline, and this till noradrenaline, this pathway takes place in our whole body, right? And in adrenal medulla, this noradrenaline gets converted to the adrenaline, right? So the first amino acid that is being used is phenylalanine, right? एंड स्टोरेज ऑफ कैटेकोलामीन्स की हमने बात कर ली थी कि कैसे स्टोर होता है, कैसे रिलीज होता है, एंड कैसे उसका रीअपटेक होता है. तो रीअपटेक 3 टाइप्स का होता है बेसिकली, बट इम्पॉर्टेंट इज टू फर्स्ट इज एक्सोनल, देन वेसिकुलर. एक्सोनल में NET पंप होता है, राइट. इट इज़ एन एक्टिव अमाइनो acid pump, right, that is present at the neuronal membrane, which transports the Na by Na plus coupled mechanism, and it takes up the Na at the higher rate than adrenaline, and had been labeled the uptake 1. And this pump is inhibited by the cocaine, desipramine, and the drugs like cocaine. The indirectly acting, so basically, tyramine and amphetamine show its action through NET only. How? Let me tell you. So here is a pump. Here is a synaptic terminal, and this is the pump NET. What is happening here? Tyramine from the outside, from the cheese that you have taken from a party, you have eaten. So वो चीज़ में से आपको टायरामीन मिला. टायरामीन आपका NET क्रॉस करके अंदर आएगा, एंड टायरामीन विल बी आस्किंग टू द नॉरएड्रेनालिन that please go out, this is my place, I will share. So noradrenaline will come out, and noradrenaline will be active on all the receptors, right? Then the indirected sympathomimetics like tyramine and amphetamine, they also gets activated by, or they show their action actively by acting through NET, right? Then vesicular uptake. Vesicular uptake is having the receptor or transporter, that is VMAT2, right? So the membrane of the intracellular vesicle has another amine pump, the vesicular monoamine transporter VMAT2, which transports the catecholamine from the cytoplasm to the interior of the storage vesicles. Then the VMAT2 transports monoamines by exchanging with H plus ions. Right, the vesicular Na is constantly leaking out into the exoplasm and is recaptured by this mechanism. And this carrier also takes up the dopamine from the axonal for further synthesis to Na. Thus, it is really important in maintaining the Na content in the Na content of the neuron. So, vesicular uptake, as the name suggests. So, this transporter is present on the vesicle. So, here NET was present here, neuronal membrane part, right, and VMAT2 is present in vesicle. So it will be managing the transport of the Na inside the vesicle, right? And extraneuronal uptake is the third type of the uptake, and it is carried out by the extraneuronal amine transporter ENT and OCT3 and other organic transporters OCT1, OCT2, and it is not inhibited by cocaine. So extraneuronal uptake is same as axonal, but axonal was inhibited by cocaine and extraneuronal is not inhibited by cocaine, right? So these things we have already studied, we are revising these things, so I will be going fast, right? So yeah, this we have discussed. Tyramine, tyrosine is there, phenylalanine is there, that is converted to the tyrosine, tyrosine is there, that is converting to the dopa, dopa se dopamine, dopamine is coming inside the vesicle through VMAT2, then dopamine is converted to the Na, then Na is released outside through exocytosis, right? Then Na का reuptake होगा NET से, then some of Na will be also entering to VMAT, right? And here tyramine is there. Tyramine can enter, or amphetamine can enter, or can take entry through this NET only, right? And cocaine can inhibit this NET, right? So these things we have already discussed. And the Na that is active, वो आगे क्या कैसे act करेगा? It will be acting on receptors, right? Alpha and beta, that are the adrenoceptors. Alpha are further of two types, alpha 1 and alpha 2. Beta is of three types, beta 1, beta 2, beta 3, right? But most of the Na or adrenaline that is released here is metabolized by monoamine oxidase and COMT, right? So these are the two metabolizing enzymes that will be metabolizing or decreasing the quantity of Na. Then adrenergic receptor. Adrenergic receptors are the membrane-bound G-protein coupled receptors which function primarily by increasing the or decreasing the intracellular production of the second messengers CAMP or IP3-DAG. In some cases, the activated G-protein coupled receptor operates K plus and calcium. So or increases the prostaglandin production, and thus they will be acting like that. So there are of two types. Adrenoceptors are of two types, alpha and beta. This we have already discussed. So beta 1 is on heart because heart is single, so beta 1 is on heart. Beta 2 is on lungs. Lungs are 2 in number, so beta 2 is on lungs, plus it is on smooth muscles, right? So blood vessels, uterus, liver, GIT, urinary tract, eye, right? Then beta 3 is on adipose tissue, and we just don't need this thing, or we don't need to remember beta 3. Then let's discuss the actions. So alpha will be constricting the arterioles, as we have discussed. Alpha 1 will be vasoconstrictory and beta 2 will be vasodilatory, right? Heart per alpha there is little action, but arrhythmia can occur at higher doses. And beta, dilatation of the arterioles of the veins, right? Beta 2. Then beta 1 causes cardiac stimulation and increase the rate and the force of conduction. Then alpha is not present on bronchus, so no other action on the lungs will be produced, but beta 2 will be causing bronchodilation, right? Then contraction of the radial muscles of iris will be causing mydriasis and decreased aqueous secretion, and no effect on the iris. Slight relaxation of the ciliary muscles, enhanced aqueous secretion will be there. Then intestinal relaxation, contraction of the sphincters, intestine, and beta 2 will also relax the intestine. Then bladder trigone का contraction होगा alpha 1 से, that's why in the benign prostatic hyperplasia we will be giving alpha blockers like prazosin. So BPH will be aggravated if trigone is contracted, so we will be relaxing the trigone so that easy passing of the urine can take place. Then detrusor का relaxation होगा beta 2 से, as beta 2 is on smooth muscles, so these all are smooth muscles and beta 2 will be relaxing all the smooth muscles. Then uterus, it will be causing contraction and beta 2 will be causing relaxation, right? Splenic capsule, alpha 1 will be causing contraction but beta 2 relaxation, so beta 2 is same and it is on smooth muscles and it will be relaxing. So references are from which book? References are from KDT, Kadzang, right? And इसके अंदर गुडमैन गिलमैन से नहीं है as such, but antibiotics में, general pharmacology में, there were references from Goodman Gilman as well. The neuromuscular transmission facilitated increased ACH release, and beta per inactive state, it prolonged the fast contracting muscle and abbreviated in the slow contracting muscle, and beta 2 can also cause tremors. Then augmented insulin and glucagon secretion, and alpha will be inhibiting the insulin secretion. And on liver, glycogenolysis will be there, and beta 2 भी glycogenolysis करेगा, and thus it will be causing hyperglycemia. Muscle पर भी glycogenolysis, so hyperlactic acidemia. Then fat per lipolysis, beta 1, beta 2, beta 3, so there will be increased free fatty acid in the serum, thus calorigenesis is there, right? And yeah, these all are the important functions, and before starting the actions we must be remembering these things. So adrenaline can only stimulate the alpha 1, alpha 2, beta 1, beta 2 and beta 3, so these are the all receptors basically. So adrenaline can stimulate all of the receptors. Noradrenaline, alpha 1, alpha 2, beta 1, beta 3, but no beta 2 action, right? No beta 2 action. So noradrenaline will be not stimulating the beta 2, and if beta 2 is not stimulated, then blood vessels per there will be no dilatation, right? Because no beta 2 is stimulated. Alpha 1 is stimulated, so only constriction will be there. Then isoprenaline, beta 1, beta 2, beta 3, no alpha action. So isoprenaline is only stimulating the beta 1 and beta 2, so it will be stimulatory at the heart, and because of beta 2 it will be causing cardiac dilatation, right? cardiac blood vessel dilatation, right? Blood vessel dilatation. So beta 2 will be causing blood vessel dilatation, and as isoprenaline cannot produce any alpha 1 action, so no blood vessel constriction will be seen. So these things will be necessary for us for understanding the vasomotor reversal of tail. देन हार्ट पर हम ऑलरेडी बात कर चुके हैं, ब्लड वेसल पर भी बात कर चुके हैं, बीपी पर भी हम बात कर चुके हैं, बट आई विल बी रिवाइजिंग दिस थिंग बिकॉज वेजोमोटर रिवर्सल ऑफ डेल इज़ द हॉट टॉपिक जो कि वाइवा में भी पूछा जाता है और यूनिवर्सिटी एग्जाम्स में भी पूछा जा सकता है एंड MCQs में भी आता है. सो वेजोमोटर रिवर्सल ऑफ डेल एंड वेजोमोटर रिवर्सल ऑफ डेल. So this is the normal graph of adrenaline, right? Adrenaline. So we'll be talking about adrenaline in this first of all. Then because of adrenaline, as adrenaline can stimulate both alpha 1 and beta 2. So because of alpha 1 there will be vasoconstriction and because of beta 2 vasodilatation. But पहले क्या होगा, vasodilatation और vasoconstriction. So alpha 1 are strong receptors, beta 2 are sensitive receptors. So to activate, if you want to activate the alpha 1, then you have to give a high amounts of adrenaline, right? But if you want to sensitize the beta receptors or if you want to stimulate the beta 2 receptor, then small quantities of adrenaline would be okay, right? So alpha 1 needs a higher dosage of adrenaline for its stimulation and beta 2 needs a lower dosage of adrenaline for its stimulation. That's why alpha 1 are strong, beta 2 are sensitive, right? Even at low doses of adrenaline beta 2 can be stimulated. Then alpha 1 are strong, so when alpha 1 is acting no other receptor can act, right? So on BP what will happen when you give a high amount of adrenaline, right? IV bolus की बात करते हैं पहले. So if you are giving a rapid infusion, then what will be there? First of all, high amount of adrenaline will be causing stimulation of alpha 1, so there will be a peak rise in BP. But then adrenaline quantity will be metabolized in the blood, right? So quantity will be decreasing. So as the quantity of the adrenaline is decreasing, so beta 2 stimulation will be there. Because beta 2 are sensitive and adrenaline is small in quantity, so the leftover adrenaline cannot stimulate the alpha 1 receptors, so the over adrenaline will be stimulating the beta 2. So when beta 2 are stimulated, then it will be causing vasodilatation and thus blood pressure will fall, right? So there is an initial rise in BP because of alpha 1 and there will be decline in BP or fall in BP because of beta 2, right? So this is the normal phenomena. But when you are giving a alpha blocker, so what will happen? So patient has already taken an alpha blocker and you are giving adrenaline, so what will happen? Wait a second, let me just clear the area first. So patient has already taken alpha blocker. What will happen? As alpha 1 needs a strong stimulation, it needs high amount of adrenaline for its activation, but we cannot have so much of stimulation of alpha because patient has already taken alpha blockers. So what will happen now? As the patient has already blocked his or her alpha receptors, Now only beta 2 receptors will be stimulated, and if beta 2 receptors will be stimulated, then there will be rapid fall in BP, and patient can even go into a severe hypotension, right? So there will be rapid fall, और ये fall इतना ज़्यादा होगा because बहुत ज़्यादा amount of adrenaline is there, and this high quantity of adrenaline is stimulating the beta 2, and if that much amount of beta 2 will be stimulated, then so much of vessels will be dilate, and इतना ज़्यादा dilation की वजह से there will be peripheral pooling of the blood, and peripheral pooling of the blood की वजह से there will be fall in BP, right? Then vasomotor re-reversal of Dale. So in reversal, patient has taken alpha blocker. In re-reversal, patient will be taking beta blocker, right? So this is the normal graph, alpha 1, beta 2, right? Now patient has taken beta blocker. What will be happening here? As patient has blocked his beta 2 receptor, so there will be no vasodilation. No vasodilation, right? Now what will happen? Only rise in BP will be seen, no fall in BP will be seen, right? No fall in BP will be seen because no beta 2 receptors will be stimulated, no vasodilation will cause, right? And if no vasodilation takes place, then no fall in BP will be there, only rise in BP is there, right, due to alpha 1 stimulation, right? And after the metabolization of the adrenaline, it will be coming towards the normal, right? Then we have talked about the vasomotor reversal of Dale, in which patient takes alpha blocker, right, and vasomotor re-reversal of Dale, and this is the phenomena that is a characterized feature of adrenaline, right? So these phenomena are only adrenaline can produce this phenomena, right? No other, because adrenaline is the substance that can stimulate alpha 1, alpha 2, beta 1 and beta 2 and beta 3. So beta 2 and alpha 1, they both are stimulated by adrenaline, right? And if you see noradrenaline, then it can stimulate only alpha 1, alpha 2, beta 1 and beta 3, no beta 2 stimulation. So only rise in BP will be seen, right? Biphasic response, we cannot see here biphasic response, right? Then isoprenaline can only stimulate beta 1, beta 2 and beta 3, no alpha stimulation will be there. So when no alpha stimulation is there, so no vasoconstriction or no rise in BP will be seen, only fall in BP will be seen, and because of beta 2 stimulation, right? Then we have already talked about these all actions. Now adverse effects of adrenergic drugs or adrenomimetics or sympathomimetics. So transient restlessness, headache, palpitation, anxiety, tremor, pallor may occur after SI or IM injection of adrenaline. Then marked rise in BP leading to cerebral hemorrhage, ventricular tachycardia, fibrillation, angina, MI are the hazards of the large doses or inadvertent IV injection of adrenaline. Then adrenaline is contraindicated in the hypertensive patient, hyperthyroid and angina pectoris, right? So adrenaline is contraindicated because adrenaline can increase BP, and if patient is already having hypertension, then there will be hypertensive crisis, and in hyperthyroid also cardiac stimulation will be high, so we don't want any adrenaline in this. And in angina pectoris, already O2 demand is on its peak, and here we want to decrease the cardiac load, and if we will be giving adrenaline, there will be increase in the cardiac load, and thus angina patient can end up into MI, right? So these are all scenarios in which adrenaline is inhibited or contraindicated. Adrenaline should not be given during anesthesia with halothane because it can cause arrhythmias, and when if patient is taking or receiving a beta blocker, then there will be marked rise in BP can be there, right, because of the unopposed action, unopposed alpha stimulation. Then now comes the drugs, adrenergic drugs. First is dopamine. It is a dopaminergic D1, D2 as well as adrenergic alpha and beta 1 agonist. So dopamine is having agonistic action on D1, D2, alpha and beta 1, but not beta 2, right? Beta 2 पे नहीं होगा, then it cannot cause vasodilation, right? The D1 receptors in renal and the mesenteric blood vessels are the most sensitive. So IV infusion of the low doses of the dopamine dilates these vessels by raising the intracellular clamp, and it increases the GFR, right? And in addition, dopamine exerts natriuretic effort by D1 receptors on the proximal tubular cells, right? So it will be increasing the GFR, it will be increasing the Na plus loss, right? Moderately high doses produce a positive inotropic action, that is direct B1 D1 action, and due to the Na release, but little chronotropic effect on the heart is seen. Then vasoconstriction alpha 1 के action की वजह से is seen, and no vasodilation can be seen because it cannot stimulate beta 2. Then at normal doses it raises the cardiac output and systolic BP with the little effect on diastolic BP. It has practically no effect on non-vascular alpha and beta receptors and does not penetrate blood-brain barrier, and no CNS effects. Then dopamine is used in the patients of cardiogenic and septic shock and severe CHF, wherein it increases the BP and urine outflow. So dopamine is used in the patients of cardiogenic or septic shock and severe CHF, wherein it increases the BP and urine outflow. Then it is administered by IV infusion 0.2 to 1 mg per minute, which is regulated by monitoring the BP and rate of urine formation. So dopamine is used in the patients of cardiogenic and the septic shock and severe CHF because we want a positive inotropic action here, right? So it increases the BP and urine outflow, and because of the increasing in the urine outflow, we get a diuretic action also here, right? Then it is administered by IV infusion 0.2 to 1 mg per minute, which is regulated by the monitoring of the BP and rate of urine formation. Then comes dobutamine. So it is a dopamine derivative, as the name suggests, dobutamine. So it is a dopamine derivative, but not a D1 D2 receptor agonist. Though it acts on both alpha and beta adrenergic receptors, the only prominent action of the clinically employed dose is 2 to 8 μg per kg per minute IV infusion, and is increased force of cardiac contraction and output without any significant change in heart rate. So it can increase the force of contraction and cardiac output without increase in heart rate, right? And without any change in peripheral resistance. So it cannot change total peripheral resistance as well. As such, it is considered to be a relatively selective beta 1 agonist because it shows the cardioselective action. It is used as an inotropic agent in pump failure, accompanies the myocardial infarction, cardiac surgery, and short-term management of the severe congestive heart failure. It is less arrhythmogenic than adrenaline, right? Then Dobutrex and Dobustat is 250 mg vial, and it is present in this preparation, right? And ephedrine is now comes ephedrine. Ephedrine is an alkaloid obtained from the ephedra vulgaris. So till now we have discussed the dopamine, the dobutamine, and now we have started with the ephedrine. So ephedrine is an alkaloid obtained from the ephedra vulgaris, mainly acts indirectly but has some direct action as well as on alpha and the beta receptors. Then repeated injections produce tachyphylaxis. Tachyphylaxis means rapid tolerance, and primarily because of the neuronal pool of Na available for displacement is small. So जो भी Na के sources हैं वो exhaust हो जाएंगे. That's why tachyphylaxis will take place, right? It is resistant to monoamine oxidase, therefore effective orally. Then it is about 100 times more potent than adrenaline, but longer acting, 4 to 6 hours. Then ephedrine crosses the brain and causes stimulation but central stimulation. Peripheral activity ratio is lower than that of amphetamines. Then ephedrine can be used for the variety of purposes, but it lacks selectivity and efficacy is low. Use is now restricted to that mild chronic bronchial asthma and for hypotension during spinal anesthesia, occasional for postural hypotension, 15 to 60 mg TDS. So the use is now restricted to that of in mild chronic bronchial asthma and for the hypotension during spinal anesthesia, and it is occasionally used for the postural hypotension, 15 to 60 mg TDS. Now comes the amphetamine. Amphetamine मैं starting से बता रहा हूँ, tyramine and amphetamine. So this is indirect sympathomimetic, right? These are the synthetic compounds having a pharmacological profile similar to the ephedrine, orally active with relatively longer duration of the action. Then they exert potent CNS stimulant action and weaker peripheral cardiovascular action. Then maximal selectivity is exhibited by dextroamphetamine and methamphetamine, right? So maximal selectivity is exhibited by dextroamphetamine and methamphetamine, which is the usual dose, produce few peripheral effects. The central actions of the amphetamines are largely mediated by the release of Na from adrenergic neurons in the brain. Then this occurs mainly by the exchange, diffusion and the reverse transport involving the transporters like NET, DAT, VMAT. However, the effects on the locomotor activity, perception and psychomotor phenomena seen at higher doses are probably due to the dopamine 5-HT release by the processes similar to that of the Na release. And in addition, amphetamine inhibits neuronal reuptake of the dopamine. The central effects include alertness, increased contraception, attention span, euphoria, talkativeness, increased work capacity. So amphetamine का abuse होता है, right? So patient when takes the amphetamine for the first time, he can feel alertness and increased concentration, euphoria effect. So he tries to abuse this drug and tries to take again and again. Then fatigue is allayed and athletic performance is improved temporarily, followed by deterioration. But he is not thinking about the following deterioration that he will be having after this euphoric effect. He can go into coma and he can end up in coma, and thus death can also take place. It is one of the drugs included in the dope test for the athletes. Then the reticular activation system is stimulated, acting the wakefulness and postponement of the sleep deprivation induced physical disability. But this is a short-lived and may be accompanied by anxiety, restlessness, tremor, dysphoria and agitation. So initially he will be having euphoria, then he will be having dysphoria, anxiety, tremors, agitation. Then use before examination to keep awake can be counterproductive and needs to be condemned. Then amphetamines stimulate the respiratory center, and especially if it has been depressed. Hunger is suppressed as a result of inhibition of the hypothalamic feeding center. They also have a weak anticonvulsant, analgesic and antiemetic action. So amphetamine is having 3 A's functions: antiemetic, right, anticonvulsant and antiemetic, anticonvulsant and analgesic. So it can act as painkiller, it can subside vomiting, and it can subside a seizure attack as well, but it is not used, right? And it potentiate the anti-epileptics, analgesics and anti-motion sickness drugs. Peripheral effects on the heart, BP are not significant, but the usual doses, which cause only slight rise in the BP, but tone of the vesical sphincter is definitely increased. Amphetamines are the drugs of abuse and are capable of producing marked psychological but little or no physical dependence. Then amphetamine abusers are generally teenagers seeking thrill or kick which is obtained on rapid IV injection, and high doses produce euphoria, restlessness, insomnia, aggression, panic, marked excitement, which may progress to mental confusion, delirium, hallucinations, and an acute psychotic state. Then peripheral component of toxicity includes rise in BP, palpitation, arrhythmia, vomiting, abdominal cramps, vascular collapse, right? Then death is usually preceded by convulsions and coma, right? Like I have said. Then repeated use is more likely to produce a long lasting behavior abnormalities. Psychosis may be precipitated. It is a anti-epileptic, but it can precipitate psychosis, right? Then tolerance to the central actions and toxic effects of the amphetamine develops, and is both pharmacokinetic as well as pharmacodynamic. Then starvation due to the suppression of the appetite produces the acidic urine. And then amphetamine is ionized more as acidic pH and is excreted more rapidly. Then the treatment of amphetamine toxicity include administration of the chlorpromazine, which control both central as well as peripheral alpha adrenergic effects. So amphetamine toxicity is treated by chlorpromazine. Treatment of amphetamine toxicity is done by administration of chlorpromazine, right? Chlorpromazine. Now comes phenylephrine. It is a selective alpha 1 agonist and has negligible beta actions, and it raises the BP by causing vasoconstriction as it is having only alpha 1 agonistic action. Then because it has little cardiac action, reflex bradycardia is prominent. Topically it is used as nasal decongestant and in the eye for producing mydriasis when cycloplegia is not required. Then phenylephrine tends to reduce the intraocular tension by constricting the ciliary body blood vessels, and it is also a frequent constituent of orally administered nasal decongestant preparation. And central effects are not seen with usual clinical doses, right? So phenylephrine भी हो गई. So till now we have completed dopamine, dobutamine, ephedrine, right? Then amphetamine and phenylephrine. Now comes the M drugs. Methoxamine. Methoxamine is another selective alpha 1 agonist and have no beta actions like phenylephrine, but has a weak beta antagonistic action or beta blocking action. Then it resembles the phenylephrine very closely and occasionally used as a pressor agent, right? Then mephentermine. Mephentermine, it produces both cardiac stimulation and vasoconstriction by directly activating the alpha beta adrenergic receptors as well as by releasing the Na. The cardiac output systolic diastolic are increased, and the direct positive chronotropic effect on the heart is generally counterbalanced by vagal stimulation due to the rise in mean BP. Then mephentermine is not a substrate for either MAO and COMT. Therefore, it is active orally with longer duration of action. Then it crosses the blood-brain barrier to some extent and may produce excitatory effects at higher doses. It is used to prevent and treat hypotension due to the spinal anesthesia, surgical procedures, shock in MI, and other hypotensive states. So mephentermine, it produces both cardiac stimulation and vasoconstriction by directly activating alpha and beta adrenergic receptors as well as by releasing the Na, right? Then selective beta 2 stimulants that is used, right? These are the main drugs, and the drugs that comes under this group beta 2 agonists are salbutamol, terbutaline, salmeterol, formoterol. So these are the 4 drugs that are used in COPD, asthma, right? So salbutamol, terbutaline, they are fastest acting, but salmeterol and formoterol, they are slow in action. So they are for prophylaxis, prophylactic treatment of asthma. Salbutamol and terbutaline is used as the emergency drug for acute attack of asthma, right? Then we have rytodrine and isosuprine. Isosuprine and rytodrine are used by uterus, right? They So these drugs cause bronchodilation, vasodilation, uterine relaxation without producing any significant cardiac stimulation, because they are having only beta 2 stimulation. No beta 1 is there, right? No beta 1 action will be produced. Then uterine relaxant, ritutrine or isoxsuprine, they delay the premature labor, right? And the hyperkalemic familial periodic paralysis में it is used. So beta 2 agonists जैसे कि हमने बात करी थी, they benefit in enhancing the K plus uptake into the muscles, so thereby lowering the plasma K levels in the so K levels in serum, right? The most important side effect is muscle tremor, tachycardia, arrhythmia are less likely. So hyperkalemic periodic paralysis के अंदर we will be decreasing the serum K plus levels, and beta 2 agonists, they benefit the K plus uptake into the muscles, so that there will be a outpouring of the K plus from serum to the muscles. Then isosuprine is orally effective long beta receptor agonist which has direct smooth muscle relaxant property, and it has been used as the uterine relaxant for the threatened abortion and dysmenorrhea, but efficacy is poor. Then beneficial effects in peripheral and cerebral vascular disease are disappointing. Side effects are nausea, tachycardia, flushing, hypotension, dizziness and tremors, right? Then nasal decongestants, जो आपकी वो ड्रग्स आती है ना जिसको हम कहते हैं नेजीवियन टाइप ड्रग्स, नेजीवियन टाइप प्रिपरेशंस जो आती हैं, जैसे एडवर्टीजमेंट्स में दिखाया जाता है कि नोज इज देयर जिसके अंदर ब्रिक्स की वॉल बन चुकी है एंड देयर इज अ ड्रग दैट इज breaking these bricks, right, and clearing the way. So that is a nasal decongestant, and the drugs that comes under the nasal decongestants are xylometazoline, nafazoline and oxymetazoline. So these are the alpha agonists which on the topical application as dilute solution produce local vasoconstriction. Local vasoconstriction की वजह से there will be low secretion of or low production of mucus, right? Then imidazoline compounds like nafazoline, xylometazoline, oxymetazoline are relatively alpha 2 agonists, like clonidine. They have a longer duration of action of 12 hours, like 12 hours, right? And it is the duration of action is more than ephedrine. After congestion is claimed to be less than that with ephedrine and phenylephrine, and they may cause initial stinging sensation, and regular use of these drugs for long periods should be avoided because mucociliary function is impaired. Then atrophic rhinitis, anosmia can occur due to persistent vasoconstriction, right? So there can be atrophic rhinitis and anosmia that can take place because these drugs, they constrict the blood vessels, right, that are in nose, right? Obviously they can be absorbed from the nose and produce systemic effects, but systemic effects are not so much produced, they are less likely to produce. Then mainly CNS depression and rise in BPs. These drugs should be used cautiously in hypertensives and in those receiving monoamine oxidase inhibitors, right? Then therapeutic uses of the adrenergic drugs as a hypotensive states like shock, spinal anesthesia, hypotensive drugs. So hypotensive states may we have to use the adrenaline, isoprenaline, dobutamine or dopamine like drugs to increase the BP, right? And in septic shock, where there is increased inflammatory mediators, increased histamine, we have to use adrenaline, that is a physiological antagonist of histamine, and thus adrenaline will be benefiting both ways, right? So one reason to use adrenaline is that it is a physiological antagonist of histamine, and second, it will be constricting the blood vessels, and it will be increasing the perfusion, right? Then cardiac arrest में you have to use adrenergic, then along with local anesthetics you will be using, because local anesthetics के साथ अगर हम adrenaline use करेंगे then what will happen is the absorption of the local anesthetic will be slow. So slow absorption होगा और ज़्यादा देर तक एक्शन होगा. देन कंट्रोल ऑफ द लोकल ब्लीडिंग, एज आई हैव सेड कि वेजो कंस्ट्रिक्शन हो जाएगा. जहाँ पर भी हमने लोकल एनेस्थेटिक दिया देयर विल बी वेजो कंस्ट्रिक्शन, एंड बिकॉज ऑफ दिस वेजो कंस्ट्रिक्शन ब्लड लॉस विल बी लेस. Then nasal decongestants, imidazoline like xylometazoline, nafazoline like drugs, जिसके बारे में हम ऑलरेडी बात कर चुके हैं. Then congestive heart failure. Congestive heart failure का aim of the treatment is to increase the cardiac function, right, to increase the inotropicity of the heart. Then in COPD, to dilate the bronchus. Mydriasis, then allergic reactions, as I earlier told you. Adrenaline is physiological antagonist of histamine, and allergic reactions are mostly due to histamine. Then ADHD में भी यूज होता है. यूट्राइन रिलैक्सेंट में भी राइटोड्रिन एंड आइसोक्सूप्राइन इज यूज. इंसुलिन हाइपोग्लाइसीमिया में भी it is used, but most importantly you should be giving glucose immediately, right? And yeah, let's end this session here. Thank you so much for coming, thank you for being here, and we'll be meeting soon. Bye guys, take care, stay healthy, stay safe, stay positive, and keep fighting for your goals. Bye. So एक बार रिवाइज कर लेते हैं फटाफट से. What say? Yeah, let's revise. एक बार फटाफट से रिवाइज कर लेते हैं. So adrenergic drugs. Adrenergic stimulation is because of the three catecholamines: noradrenaline, adrenaline, and dopamine, right? And the synthesis of the catecholamine कैसे होता है? So catecholamine are synthesized from the amino acid phenylalanine, right? Phenylalanine, and tyrosine hydroxylase is the specific and the rate limiting enzyme, and its inhibition by the alpha methyl p tyrosine results in depletion of the catecholamines, and this inhibitor can be used in pheochromocytoma before surgery and in inoperable cases. And all other enzymes like catecholamine synthesis is rather non-specific and can act on closely related substances. Example: dopa decarboxylase can form 5-HT from 5-hydroxytryptophan, and alpha-methyl DA from alpha-methyl dopa. These things are not so important. This is important. Phenylalanine is converted to the tyrosine, then tyrosine is converted to the dopa. Dopa will be converting to dopamine. Dopamine will be converting to noradrenaline. Noradrenaline will be converting to adrenaline, but this step is specific for adrenal medulla. Then storage of the catecholamines. Na is stored in the presynaptic vesicles or the granules, right, or the granules within the adrenergic nerve terminal, and the vesicular membrane actively takes up the dopamine from the cytoplasm, and the final step of the synthesis of the Na takes place inside the vesicle, which contains the dopamine beta hydroxylase. So dopamine comes with dopamine beta hydroxylase, and dopamine will be converted to the noradrenaline, right? And the cytoplasmic pool of catecholamine is kept low by the enzyme monoamine oxidase present on the outer surface of the mitochondria, right? And then what will be released from the vesicle? So vesicle से क्या क्या निकलेगा? vesicle से सबसे पहले तो नर्व टर्मिनल पे क्या क्या रिलीज होगा? न्यूरोट्रांसमीटर, एड्रेनालिन और नॉरएड्रेनालिन, देन एटीपी, देन डोपामिन बीटा हाइड्रोक्सिलेज जो लेफ्ट ओवर है, देन क्रोमोग्रेनिन ग्रेन्यूल्स. एंड दिस क्रोमोग्रेनिन ग्रेन्यूल्स और क्रोमोग्राफिन ग्रेन्यूल्स की वजह से द नॉरएड्रेनालिन विल बी कन्वर्टिंग टू द एड्रेनालिन इन द एड्रेनल मेड्यूला, right? Then indirectly acting sympathomimetic amines like tyramine and amphetamine, like I have earlier told you, that it will be sitting at the place of noradrenaline, and it will be increasing the release of the Na, right? Na को ये they will be expelling out noradrenaline and adrenaline, right? And thus they will be increasing the functionality, or they will be activating the sympathetic stimulus. Then axonal uptake की हमने बात कर ली थी, vesicular uptake extra neuronal की कर चुके हैं, right? And then adrenergic receptors, they are of two types. This we have already discussed. Yeah, so alpha 1 and alpha 2. So alpha 1 are, so जो alpha 1 है that is present post junctionally, and जो alpha 2 है it is present pre junctionally, right? So wait a second. Yeah. So alpha 1 post junctionally, alpha 2 pre junctionally. So alpha 2 will be acting like brakes. Then alpha 1 का function कहाँ होता है? GU, smooth muscles, vasoconstriction gland, gut, liver, heart. And selective agonist is phenylephrine, methoxamine, and selective antagonist will be prazosin. Then alpha 2 का selective agonist will be clonidine and antagonist will be yohimbine, right? Then we have discussed all these phenomena and the vasomotor reversal and re-reversal of Dale, then adverse effects. Then we have discussed the dopamine, that it is agonistic on D1, D2, alpha, beta 1 receptors. Then dobutamine, D1 and D2 receptors पे नहीं act करता, it only acts on the alpha and beta receptors and it is the preferred drug. देन एम्फीटामिन भी बात कर ली थी, डोप टेस्ट के बारे में बात कर लिया था एंड इट प्रोड्यूसेस अ टेम्परेरी यूफोरिक इफेक्ट एंड उसके बाद एंग्जाइटी होगा, वॉमिटिंग होगा, एब्डोमिनल क्रैम्प्स होगा, वैस्कुलर कोलैप्स होगा एंड दस डेथ कैन ऑल्सो कॉज, बट डेथ से पहले कन्वर्जन्स और कॉमा हो सकता है, राइट. देन फिनाइलेफ्रिन की बात कर दी, अल्फा 1 agonistic and negligible beta action is produced. Methoxamine is selective alpha 1 agonist and no action, no beta action. And mephentermine, they directly act on beta, alpha and beta both receptors. And then we have talked about the salbutamol, terbutaline, sarmetrol, formoterol, rytodrine, isosuprine, right. Then nasal decongestant, imidazoline like drugs, nafazoline, xylometazoline, oxymetazoline. Then we have discussed the therapeutic uses, hypotensive states, cardiac arrest along with local anesthetic, control of the local bleeding, nasal decongestant, CHF, COPD, mydriasis, allergic reactions, ADHD, uterine relaxants and insulin hypoglycemia. And yeah, thank you so much guys, we'll be meeting soon. Take care, stay healthy, stay safe, stay positive and keep fighting for your goals, and bye guys.